Good morning, everybody. Let's get started. It's my pleasure to introduce today Dr. Thomas Grau, who's one of our faculty member in the Division of General Internal Medicine, and has a long pedigree in medical education. He served as a program director, is now with us working in our Master's of Medical Education, supporting our fellowship program, teaching our residents, working toward his PhD in education, which we're so impressed by. Today, one of the roles he serves for us in the medicine residency program is he really spearheads our academic coaching program. And so this is a program that that Tom has a lot of experience in and has put into place for us to help our residents who are struggling with their board performance, sort of knowledge base. And so one of the things, he's got a very nice program developed with a lot of structure to it. So we thought this was we all struggle with these issues. So we thought that this would be a great topic to have Tom share with us. And I see lots of medical school faculty in the room, so we're excited to branch our coaching.
Thank you. So I don't really need to say anything else because so I've been doing this for about 7 years, and it's kind of a work in progress. It's been iterative. I've changed it, and we'll see. And I'm willing to take feedback. I know there's a lot of experienced educators in here, so if you have some things that you've tried with people that struggle with medical knowledge, I'd be interested in hearing, or resources that you know of. I have one disclosure, and that is that I am for the next year on the Board of Governors for the American College of Physicians. Actually, Missy has been elected as my replacement. So, and the reason I put that up as a disclosure is I am going to talk about ACP products a couple times during the disclosures, during the presentation. So you do need to know that. I have no other financial disclosures.
Sadly.
So, sadly, right. All right, so I'm going to ask you guys to kind of decide how you're going to do. So let's just suppose you're a new faculty member. You picked out your picture for the website. You're waiting for those patient surveys to roll in and give you some big score that has nothing to do with the kind of doctor you are, but it is going to. And then your program director calls you and says, hey, we just got you credentialed, and we have a job for you. We have a third-year resident who scored poorly on his in-training exam, and we want you to work with him. We've already set up the meeting, so you're going to meet with him next week, and we'd like you to come up with a plan. He further says that this is important to us because our board pass rate has been low the last few years, and we want to make sure no one fails. So it's your job to get this person up to speed. Any questions? And of course you're like, no, I don't know. So here's his ITE score. I'll just go through this because I know not everybody uses this. So this is the ACP creates in-training exam that all the residencies in internal medicine use. They create it with the Association of Program Directors. It's co-created. I don't know why their name appears on the top. But this is the overall score report. There's a lot of pages in it, but this is this person's total correct score. So they got 60% of the questions correct. And then the ACP will rank you nationally versus your class. And so this person ranks in the 10th percentile and is a PGY3. And then they go into a bunch of other scores, and then they give you your percentile in these scores. You can see there's a wide range of these. There's a smaller number of questions, so the validity of these isn't much, but the validity of the percentile is good. All right. So what I want you to do is kind of turn to whatever group you're in, like 4 or 5 people, and I want you guys to tell me what you're going to do. I'll give you 5 minutes. Talk to each other about what you're going to do to help this person. How are you going to help this person be a better learner? So you're going to meet with him next week. What are you going to tell him?
I would like to know, like, what his career interests are. Because I noticed he had like an 80 in cardiology and 40 in oncology. So he was just one of these pre-cardiology talking about maybe their lives. But I always recommend this. It's still the best. Yeah, how you study.
I mean, residents study.
Oh yeah. They, oh, you meant to study for the big? No. Not for that. I think it's for the EBM.
Yeah. But I mean, but the ours was so
I mean, they know that if you score above the 30 to 35 percentile on this, there's a chance of getting so that's the type of point that if you're above that
why are we making
relatively
yeah.
right? Not absolutely no.
So you would
Resident timing issue.
someone not your someone
You know, teacher, we would have an institution in this scenario. We want to know, like, so rheumatology was low. Are all your residents low? That's something I'll have you think. You know, if you have a shitty rheumatology department, you know, everybody's
That way, like, you can go on and on about, like, characters and some other stuff. Right. I just have been studying almost like
All right, I'm gonna go back because I just want to make sure I stay on time. Any thoughts that people had about what they wanted to do? Any thoughts you want to share? No? Mike?
So I noticed there was a lot of variability in the sections.
Yeah.
You know, like it was
Yeah.
80 in cardiology and 40 in rheumatology.
Yeah.
And you
Yeah.
kind of dig into that a little.
Uh-huh.
Was this like a pre-fellow, you know,
Right.
kind of guy?
Right. Right.
Look at how his distribution of the lifers is and stuff like that.
Right. That's a common thing is that, and we all do this, right? You know, that we know from CME that you go to the things you like. So you actually pick the wrong things to go to because you pick the things you like. So I always go to preoperative evaluation, which is probably something I don't really need knowledge in. So learners tend to do that too. And I heard you guys talking a little bit about maybe this is a program problem. There is a program report that goes out for this, and that helps the program directors identify that. But for this particular exercise, we're going to talk more about the individual issues. Okay. Anything else anybody wanted to add? All right. So what do you think the traditional advice to residents with low scores on their ITE is? I thought that too. And I thought that too. And I've said that when I've given this kind of talk before, but it's actually not. That's the most common thing that appears on the evaluation. So on their evaluation, it's read more. But when they sit and meet with their advisors to talk about the ITE, that's not what occurs. And I'm going to tell you later what does occur. So, okay. So I'll talk a little bit about IT and training exams, not too much, and then I'll talk about improving medical knowledge and go over my program. And then I'm going to spend a little bit of time talking about the lessons I've learned because, like I said, it has been iterative for me because I keep learning new things about this. So why is the ITE important? So the ITE was for internal medicine was created in 1988. I know that because I was in the first residency class that took the ITE. And it was created because faculty are notoriously bad at medical knowledge. We know this because the ABIM asked people to say, how smart are these residents? And those don't really correlate to whether they're passing the board. They correlate very poorly. So faculty are notoriously inaccurate at that. For us, the low ITE scores, we know there's a lot of data, I'll show you just a little bit of it, that it increases the risk of our certification exam, the ABIM. And also for internal medicine, and this is true for some other residencies, our board pass rates are tracked by the RRC, and it's used as one of the accreditation things. And not only that, our board pass rates are publicly available. So you can go onto a website, you can Google RRC or ABIM residency pass rates, and you can see how every program does. So there's a lot of, and the applicants look at this, right? So this is one of the things they look at when they're trying to pick programs. We also know that baseline knowledge is important for learning. The more you learn, the more you know at baseline, the more you learn, the more quickly you learn. And this has been shown in multiple different educational fields. And I created a pretend graph to do this. So this is not real data, but basically the slope, right. They say that 80% of data is made up, something like that. But the slope of learning is higher if you have higher baseline knowledge. So if you can get their baseline knowledge up, they're going to learn faster, and I think that's important for us to think about. So of course it'll impact on their ability to learn. It impacts on their ability to care for patients. That data is there. It's not as strong as we'd like, but for instance, the ABIM has followed and knows that people that don't pass the boards are more likely to have licensing actions for patient care related issues. And I think most importantly for me, they're a marker for residents who are not learning effectively. So if you see somebody whose ITE scores is really just not going up the way it should, that's somebody who's not learning effectively, and I think that's something as educators we can intervene on. Okay, so just one, this is ABIM data, and basically there's tons of studies on, how well the ITE predicts board passage rate, and they use different ways to cut up the data and stuff like this, but this one basically broke people into quartiles. So this is the highest quartile on the ITE, and this is the lowest quartile. And what you can see is basically that if you're in the low quartile, you have about a 32% chance of board failure. So, a lot of those people pass, but many don't. But you can see you have failures in each of the quartiles until you get to the top quartile. That's so probably the top quartile, you don't even need to worry about them in terms of if your only goal is to have them pass the boards. Those people are doing fine. But some of the other quartiles, there is board failure. So the problem with read more, in my opinion, so read more is what we say. The problem is that that's kind of overwhelming to these people. They know their scores are low. They've looked at it, and it's a little overwhelming. They don't know what that means. It's also not a frame of reference for them. Like, how many people in this room, you don't have to raise your hands, but how many people in this room have been told to read more? I mean, like everybody, right? So everybody gets told to read more.
How many have said it?
Right. Everybody gets told to read more, but they don't really have a frame of reference that they're the people that really need to read more, and they don't actually know how to do it. Some of these people are already reading, but they're not really being effective in their learning, and that's another issue. So those are some of the problems with read more. Is it's really not a clear guideline for them. It doesn't set a goal for them. And it doesn't tell them enough specificity. So I'll talk a little bit about my process. It's based on 3 components. You notice this slide is different. Drew Klein taught me this. There's this new slide manager thing on PowerPoint where it can show you neat ways to do slides. I only did one because it messed up my my layout. But anyway, it's really cool. So anyway, my process is based on 3 components. One is self-regulated learning theory, which we're going to talk about. The other is a lot of the new neurocognitive science on effective learning, and we'll talk a little bit about some of the basics. I know this group has talked about this a lot, and so you guys kind of know these things well, but I'll tell you how I operationalize them. And the other I kind of stumbled along is, all the colleges have these learning centers, and I didn't really know much about them, but they have these wonderful learning centers, and they're dealing with the same issue we're dealing with, which is as people go up the academic hierarchy, there's a certain number of people that can't make that next transition. And they deal with a lot of people that have that trouble making that transition from high school to college. And what they found is that these people have deficiencies in the way they learn. And so they've created some pathways, and I've blatantly stolen from them in my program, and I'll show you that, to do that. So my goal for this is to help them pass the boards, but my little bit below the surface goal, the thing I really care about is to help make them better learners. I feel like if we can make them better learners, that's actually going to provide a better societal benefit long term. So these are the 3 references that I am taking heavily from. Okay, so as you're thinking about these problem learners, there's 5 things that learners need to do. They need to put time in, and they need to put effort in. And those 2 things are not always the same. Some of the people put a lot of time in, but it's not effortful time. There's a passivity to learning that we see sometimes, and you really need to get them activated and active learners. And they need to practice, and they need to reflect. Feedback is very important for helping them, but not completely built into my system, other than a lot of self-feedback. So one of the things that we talk about is self-regulated learning theory. So self-regulated learning theory starts with some sort of task, a clinical task in the center. And there's things you do before that task, things that you do and think before that task. There's things that you do during that task, as you're studying. And then there's things you do after you've studied. And it creates kind of a cycle. And there's a lot of deficiencies within these various subgroups of our people that are struggling. And I'll come back to that self-regulated learning theory again. So my process consists of 5 components, and I'll go into each one of these in detail. So I have 3 sessions. The first one's an hour long, where I do most of this. And then the second 2 sessions are about 30 minutes long. Sometimes the last one's even 15 minutes long if they're really doing well. And just kind of reviewing things. I also give them a guidebook, so I go over a lot of information, and then we give them a guidebook that I can make available to anybody if they want. Like I said, I did blatantly steal from these people, so I didn't want to put it on the AME website. I guess I shouldn't keep my mouth shut right now. So anyway, we give them a guidebook that helps them work through that, and Drew Klein actually helped me kind of operationalize that guidebook.
Hey, Tom.
Yeah.
So you have them review sample questions. Do you do that with them? Do they articulate their thought process?
I'm going to talk about that process in just a second. Yeah. So the first session, I discuss their prior experiences with standardized tests and find out a little bit about how they've dealt with this in the past, and what kinds of things they've tried and how they've worked on improving their knowledge of the past. I really review the ITE scores because most of them don't really know what it is, and I talk about this is what the percentile means. This is how much it should go up by year. If it doesn't go up by that much by year, you're not adequately learning in it. I'm really trying to get them an idea, in terms of behavioral change, that they're a little off the mean, and that to try and motivate some of them that this is important and you need to be pushed a little bit. We discuss the data on board pass rates in a little more detail than I do. And then I have them do 2 to 3 board style questions, and I'll show you what I do. So this is a board style question, and so there is the STEM, and then there is the question, and then there are the answers, right? And we go over that. There's the STEM, and then there's the question, and there's the correct answer, which is one of the answers, and then the other answers are distractors, and that's a great term. Some of them haven't even heard that term, but they're meant to distract you, right? That's what a distractor is. So why don't you guys read the question? So what I have them do is read the question, and I said, as you're reading the question, think aloud. Like, tell me how you're thinking through this question. If during a question you're the type of person that highlights or underlines things, do that. And I just have them read the STEM. So I'll have you guys read the STEM. If somebody can tell me when they're done, just raise your hand, just so I know about. All right. Okay. So then I say to them, okay, so they've read the question, and this is actually a pretty straightforward internal medicine question, but they almost always most of the learners get it wrong. Some get it right, but most of the learners get it wrong. It's a pretty forward. So then I'll ask them, well, what do you think the answer is going to be, or what do you think the question is going to be? What do you think the question is going to be? And for this one, they usually say, I think it's going to be diagnosis. I think they're going to ask me what the diagnosis is, and indeed, that's what it is. So.
It's interesting that you do it that way, because I think a lot of students are trained to look at the question first before even reading.
Right.
But you don't recommend that as an approach to testing?
I don't do that here. I don't recommend that. I don't go a lot into test technique. I actually don't, Jason, because I don't think that's my area of expertise. I'm more into knowledge building. But I just want to see how they're thinking through a question, where they put their emphasis, what things they think are important, what things they chosen to ignore. And so I'm trying to learn that a little bit. But yeah, I mean, I do recommend when we talk that they read the question and then look at the answers. A lot of the students actually don't look at the question, they look at the answers first, and then they try and figure it out. So.
Brian Heister has a paper about different styles, and that some are effective, some are ineffective. And I can't remember which were which. As I'm trying to remember it, but you just read the answers first. It's not
Yeah. So then these are and then I say, oh, okay, what do you think is the answer? They've already told me what they thought the answer was going to be, because when I got the question, before I showed them the answer, I say, what do you think the answer is going to be? And then when they see then these questions come up, and I ask them again, okay, you're going to stick with, you're going to stick final answer, you're going to stick, and a lot of people change their answer when they see the answers. And a lot of the students will change their answer from the correct one to the incorrect one when they see some of these other things. They see these things, and that they do that. So in this one, the answer is arterial claudication, and there were some distractors in there. There you go. The numbness. There's some distractors in there. The numbness, the age, and that kind of push people. But it's a pretty classic presentation of arterial claudication. Okay. So in terms of self-regulated theory, in here we're working in these two areas, right? We're working in, like, as they're going through the questions, what's their metacognitive monitoring, and what are their task strategies for answering the question, and are they focusing on things? And then I ask them, why do you think I got it wrong, or what made you change your answer? And that's kind of going into this part of self-reflection and causal attributions and self-evaluation. So a lot of them just don't have a lot of confidence in their ability, and when they see another answer, they say, oh, I think that might be right, even though I chose the right one. Anyway, we could talk a long time about this, but I'm going to move along. So the next thing is back to the self-regulated theory, is instilling a growth mindset. A lot of these people really feel like, I've always been a bad test taker, I'm always going to be a bad test taker. And we talk about how you can improve your knowledge and how people have done this, and it's been beneficial to me that I've done it for a few years, that I have a lot of success, and so I can kind of encourage them that yes, we have successfully brought up people's scores. It's just like any skill, you can improve it. Yep, Bob.
They all got in med school, so they must have done okay on the academic math. How do they cognitively explain their bad test takers how they did okay?
So it's a diverse group. So it's not a homogeneous group, but a large percentage of the group were lower scorers on their MCATs and lower scorers on their USMLE, and so this has been something that they've struggled with before. There are some people that are good scorers, right? Have been good scorers, and this is really their first one. And I don't have a great explanation. Some of those people just haven't been reading during residency. They just think that residency is more of an experiential thing, and so they do experience and they don't read or they don't take notes during lectures. But anyway, all right. Oh, so anyway, instilling growth mindset. We're kind of working on that forethought, the motivational, beliefs. Do you feel you have the self-efficacy to do this? And I'm trying to help them in that area. Are you interested in doing this? Like, is there a real goal? And so that's why I kind of, we push the boards a little bit, but I also say that this impacts patient care and it's important for patient care. So then we talk about effective and ineffective learning strategies. And I spend a fair amount of, this is the most of the session that I spend on this. And so just a little bit talking about where I'm spending. This is from Willingham's book, Why Students Don't Like School. And basically, information comes into your brain from the environment, so you have to be paying attention, and then you put it in working memory, and then you move it to long-term memory. And what we're trying to do is, help them understand how to process stuff from working memory to long-term memory, and even more importantly, how to pull it out of long-term memory. That's the big rub that most of these people have. So I'll go through this briefly because I know you guys know a lot of this stuff, but basically in working memory, you can only get 6 to 8 items of information. You can only hold that in working memory for a short period of time. You can increase more by storytelling or chunking or some of those other things. And then it's moved to long-term memory, which is where a lot of the problems occur. Long-term memory, the neurocognitive science says it's unlimited storage capacity. That's kind of the belief. But the problems occur with retrieval, recalling the information at a later time, and transfer, applying the information in a new setting. They may have learned about osteoarthritis sitting in a classroom in their second year of medical school, but when they come in to clinic and some person says, "Oh, I heard all over," they're having trouble transferring that information to the new setting. The initial knowledge in long-term memory is really fragile. They call it memory traces in the neurocognitive science. You can strengthen that by consolidation, so the brain reorganizes and stabilizes memory traces. There's a lot of ways it does that. One is going to sleep, so sleep helps. One is taking a break, that helps. But others is trying to use that information, retrieving that information. The retrieval process not only helps you retrieve it, it stabilizes the memory and helps you retrieve it at a later time. So it kind of builds on itself. And so the end result of all of this is that you have a more complex representation of that information. You've connected it to other things and they call that a mental model, kind of like what we call an illness script. These are the big 5 of the science of learning. So one is retrieval practice. So we know that trying to retrieve information, quizzing, testing, flashcards, all of those things stabilize that knowledge and make you more likely to be able to recall it when you need it. Interleaving is where instead of studying the same thing, you study different things. The example that you hear a lot is if you want to learn how to hit a curveball, you don't have somebody throw you 40 curveballs. Because part of learning how to hit a curveball is knowing when a curveball is different than a fastball and different than a changeup. And so you interleave that knowledge. So if you want to be a good curveball hitter, you have them do things. Same thing with medical knowledge. We interleave it, and it helps them find connections between it. So if they study nephrology one day and cardiology the next day, that helps them understand things. It certainly helps them understand concepts like cardiorenal syndrome or diuretic usage and those kind of things. Yeah.
Thoughts about learning non-medical things, so reading novels or science, non-medical science books. Is there any interleaving benefits to that?
I think they believe there is. I don't know that that's been studied. People talk about that, but to be honest with you, I don't bring. Yeah, right. I don't bring it up because they're a little overwhelmed when I tell them how much I'm going to make them read. But I think they're. I mean, that's right. Classical liberal arts teaching is that, so. All right, and then spacing. The spacing is 2 things. One, you should do your learning spaced, and you should do your retrieval at appropriate spacing, and I won't go into great detail on that. Generative learning is where you create make the mind more receptive to new learning. So you do things to make them more receptive to new learning. So for instance, if you, like I teach preoperative evaluation, and then I used to give them questions at the end. It's actually better to give them questions at the beginning before you've taught the material. Now they're primed to learn that information. They say, oh, I don't really know. So they're primed to learn that information. So that's generative learning, and you can embed that into their teaching. And then elaboration is creating deeper layers of meaning in the information, connecting it to things they already know, posing questions, those kind of things. So I tricked you guys, like when you guys had to talk for 5 minutes, that was generative learning, because hopefully I created a need for you to say, oh gosh, I might have to do this someday. I'm going to pay more attention to Dr. Grau. So let's see. We talk a lot about reflection, and this is a good learning technique, but it really is kind of a little bit of retrieval practice, a little bit of generative learning, and a lot of elaboration. So reflection, which is a good thing, actually incorporates some of those other things. Okay, so I spend a lot of time on that and go over that. I go over it in more detail. We also give them a booklet where they can kind of look through it, and we give them some references. If they have time, I like them to read that book, Make It Stick. It's a really easy read, and it's really practical. So the other thing is I'm talking with them is just trying to help them understand where we're going with their education. They undergrad, they did a lot of understanding and remembering. And we're really kind of moving up this thing. We're asking them to analyze, apply, and sometimes evaluate information. And they're doing a lot of this on the wards, but I don't think they're always connecting the understand, remember to what they're doing here, And so trying to get them to connect those pieces of the pyramid and see that even though you're analyzing a neat case, sometimes it's good to go back and try and understand the facts behind, okay, an ACE inhibitor is the best medication for them. Well, why is that? Why is the ACE inhibitor really the best medication for a diabetic? So having them go backwards a little bit. Okay, so this is my study plan. First, reading 150 minutes a week, and then I tell them to use the study cycle, which I'll show you in a sec. So I want them to read with what I call intention. And again, this is from the McGuire book. Those of you that are quick math people will figure out that my 45-minute session consists of 50 minutes of work, but I just noticed that this morning. So anyway, they kind of preview the reading, then they read with intention, and I give them some specific things I want them to do. And then they take a break, and that's to take advantage of that consolidation. And then they do a little bit of review. And so this is what I want them to do. I have a 45-minute version and a 25-minute version, depending on what their day is. And that's what I want them to do. All right, retrieval practice. See if you guys can write down the big five. No, nobody wants to do it? You got them? Oh, I have pens in the back. So. Okay, see if you can remember the big five. And so retrieval practice, if the best way to do this is to push them, this is called free recall, where they just write down what they learned about a topic, and then they do it. And you really try and push them hard to see if they can get to the five of them. So those are the five. So as you can see, the study cycle kind of takes advantage of some of these things. So the preview reading is really generative learning. The reading with intention is a lot of elaboration, and then the review is a lot of retrieval practice, and then the break is consolidation. That break is actually really important. A lot of the learners want to just read 3-4 hours a day on the weekend because that's when they have the time, but it's better from a spacing technique if you space it out, and it's also better if they take breaks during the period of time. Your mind actually works on that information while you're doing that. Yeah.
Tom, do you give them any advice in terms of reading on patients that they're presently seeing? That's a tactic that I often take.
Yeah, I think that's a great tactic. I do tell them to read on patients they're seeing, and a lot of them are already doing that. But I also tell them to read broadly because the boards are going to test you on things that you're just not going to say. There's always a test on Lofgren syndrome on the boards, and you can go through 3 years of medicine and you don't get it. So they do have to do that. But I think that's a good way, because now you're looking at that pyramid, you're working throughout the pyramid, and that's an effective thing. The other thing that we tell them to do is at the end of the week, kind of think about, what did I learn this week? Or, and what cases confused me? What do I need to do more? So that's the other thing, is that, so my study plan includes a lot of these things: reading, interleaving. But I also think that a lot of these people are not taking advantage of the learning we're already giving them. They're not optimizing that learning. And so learning from conferences and teaching rounds, taking notes, identifying key points, connecting it to other knowledge. I really push them to, if I go to noon conference and it's a talk, there's almost nobody taking notes, even though we know that notes are really effective. And there's almost nobody creating a summary at the end. And so I take these people that are struggling and say, these are things you should do. You should take notes at the end of the session, and a week later, you should say, what do I remember from last week's, talk about hypertension? What do I remember? And that's recall. So they do 150 minutes of reading. I really try and get them to learn more from their conferences, their teaching rounds, their patient care. And then they do 75 minutes of recall practice. So this is a lot of work, right? 225 minutes. That's almost 4 hours of work a week. And we kind of talk about how to do that. I let them create their own study plan, but I review it the next month and I go over it and make sure it has recall in it. I make sure it has dedicated reading. I don't tell them what to read, although we do use the MKSAP a lot because it's such a good, it's well done. It's done with the science of learning in mind. They can do practice questions. There's a flashcard thing. If you get the higher version of the MKSAP, there's a way you can create your own flashcards, and you can pre-test yourself, you can post-test yourself. So if you wanted to do all of these things, it's all built into that program. And there are other proprietary ones that are just as good, just have the same thing. I just don't have as much experience with them. And then this I just make sure that they're using retrieval practice, that they're using reflection, that they're using elaboration. And then I kind of answer questions about techniques. A lot of them will realize that this feels hard. It doesn't feel as good as rereading the same thing over and over again, but it's more effective. And that's, we try and talk about that real learning feels hard. It's a struggle, and that struggle actually consolidates that thing in long-term memory better. But it's a struggle. Like when I asked you guys to recall those things, you were like, oh, come on, man. I'm just sitting here going to a lecture. But if you did it, you got a little bit more. Yeah, I'm just having lunch, man. Why does he have to give me questions? Questions were medical school. Yeah. And then the last session mainly used to answer any questions. We talk about how to effectively use questions to learn. And actually, Drew Klein kind of calls it MKSAP Make It Stick. So it's a specific document that's based on the MKSAP, which are in our residency program that's bought for them, so they already have it. So lessons learned. I'm good on time. So lessons learned. I'll take any questions right now if anybody has any questions about what I do. I went over it a little bit faster because I wanted to give you guys an opportunity.
You assume that the defect is a achieving knowledge defect as opposed to a psychiatric illness, addiction.
Yes.
Affect?
Yes. And that's. I don't know. They come to me, if they're in my advisee, I would, but they come to me through their advisors, and my assumption is that they've talked about that. They're kind of sent to me as somebody who has that. But you're right, that is a weakness of my system, and that's actually one of my lessons learned, is this works well for most people if it's a knowledge deficit, but it's not specifically focused at clinical decision making, which is another problem, right? Because the questions we're talking about them are clinically based, so that's a problem, and it doesn't get to things like motivation and other things. And I also believe that there is a group of people where there's something going on that I'm not getting, right? Because I've had a lot of success with that, but I've had some people that haven't done well, and sometimes that has surprised me based on, how they've participated in the program and stuff. So I think this gets 80% of the problem, but I don't think it gets 100% of the problem. And I think that's one of the.
Have you ever thought about, or like, what are your thoughts on creating like a little community, or maybe like linking some of these students together after you start your meeting them to see if maybe like as a group they can make their skills better, or see if maybe there's some peer-to-peer connection.
So those things work. Learning communities work, and creating, and doing that. That's, now they're more actively involved in the learning. They're creating questions, they're quizzing each other. All of those things work. I feel like when they come to me with confidentiality, that I am helping them, and I don't tell any. So I've never tried to create a community amongst them. In fact, I don't put out like on my schedule, Tom Grau is coming in for remediation. I really try and just make it more of a coaching thing, but I think there's value to that, So I just don't know how to link them together without violating their academic confidentiality.
I don't know how much detail you want to go into this, but when people are doing questions,
Yeah.
I always have the concern that they get the right answer, they're happy, and they move on. If they get the wrong answer, they look what the right answer is, and then they're happy and they move on.
Right.
Or they feel terrible that they didn't know it and they move on.
Right.
So what do you tell people about questions?
So that's actually one of my lessons learned is when I talk to them about what they're doing. A lot of these people who have pretty significant knowledge deficits they say, I learn best by doing questions. I just do questions. I learn best by doing questions. And questions are a good form of retrieval, but retrieval only works if it was there in the first place, right? And so I think what they're getting, I don't like the people that just do questions. Now, you saw those quartiles. Those people that are in the higher quartile, they probably have a lot of baseline knowledge, and that's retrieval for them. But these people in the lower quartiles, I want them doing questions on things they've recently read or read. It doesn't have to be recent, but some things they've read. And that's one of my biggest struggles is getting them to do more reading and less questions. They're like, I don't have enough time. I just have enough time to do the questions. I really want to get through this question bank, and then I'm going to do this question bank. And they have like a plan of question banks. And again, I really worry that that's not retrieval practice if it's not in there to begin with. Yes?
It doesn't matter how they read, whether they read on a computer, whether they read a book, whether they watch a media thing.
Yeah. I don't know. I mean, the nice thing about internal medicine is there's lots of different ways to learn about the board. So there are video online productions and things like that. I think that it's fine for them to learn that stuff, but I think it has to be active. And I worry, I went to that medical student thing, and I thought that was kind of cool because the medical students are doing a lot of the things that I just told you are effective. But they're also doing a few things that are ineffective, like probably speeding it up and watching it at 1.5 speed. I just don't believe that's the active learning. I just don't believe. So I do worry that some of that is a little too passive. So, I mean, I'm a reader, right? So you tell people to do what you're comfortable doing. So I say read, but some of them will listen to things on tape and listen to things, I just don't. I mean, I used to listen to medical stuff in the car, and I don't know how much of that I retain. So I think multimedia is a good idea. Multiple ways of entering the information in, because you're building on elaboration. You're seeing things from a different way. But I do worry if you just focus on a more passive thing like listening to a tape or watching a lecture. So.
Probably said this today or another time that I've been in the room with you talking about this, but this usually is deployed for PGY 3.
Yes.
Would you, if you had a PGY 1 or 2 with sufficient scores, would you do a similar plan, less intensive? I mean,
so
his time commitment wise, it's a lot, but it also seems like the best way to build.
So I can get away with telling a PGY 3 who's worried that he or she is going to fail the boards. I can get away with telling them to work 225 minutes a week.
Right.
With my now I don't get referred people unless they're in that PGY 3 category. But I have advisees myself, and for my 1s and 2s, for my 1s, I just tell them to really take advantage of learning on the wards and learning on conference, and do some reflection and do a little bit of reading for the first 6 months. After the next 6 months, I tell them they should be reading like they should be exercising. So 5 times a week, 30 minutes at a time. That's, so. And I get about the same results that I do when I tell my patients to do that.
Can you tell the ones with good ITE scores that and the ones with
Yes. Yeah, I do, but I really push it on the ones with the lower scores because I really believe that. So one of the things that you guys are probably figuring out as you're sitting here is, I already do that. I do that. I do that. And that's another lesson learned is that, the good learners have already figured out a lot of this stuff. They're already drawing like summaries of things, and they're already going to lectures and taking notes, and they're already saying, oh, Dr. Painter talked about something that I didn't know anything about. I'm going to read it. They're already doing some of those things. But some of the people that are struggling are not doing those things. And so I'm telling them to do things that some of you guys are probably already doing. Although there probably were 1 or 2 things here you go, oh, I don't do that. But talented people have ways of overcoming these things. So, okay. So lessons learned, we've talked a lot about this. I told you the most common advice they get from their advisor is nothing. Silence. They don't even mention the low ITE scores. If they do mention the low ITE scores, many of the advisors will say, but you're doing well, your evaluations look great, so I wouldn't worry about it. And to me, that's bad advice that we give them. Because remember, it was created because we don't know how to assess medical knowledge. So we already proved we're not. So this is a piece. So that's the most common advice they get from their advisors. And sometimes when I bring out the ITE score and go over it, it's the first time anybody's ever shown them what those things mean. And so it's one of those things where we're really polite and we're really nice, and we look at somebody who's doing well otherwise, and we just want to give them the benefit of the doubt. I talked a little bit about the current strategies they're doing. Like I said, most of them are just doing a lot of questions because they go to their classmates and they say, well, what are you guys doing? And they take advice from their classmates. But I think they need a little bit of a different program than what's working for their classmates. We talked about understanding. They have low self-efficacy. A lot of these people think that they can't do this. They've kind of conditioned themselves to say, I'm not good at taking these kind of tests. And so kind of building that growth mindset that this is a skill that you can learn. You're going to have to work hard, and you're going to make some mistakes, and this is going to be hard, but you're going to get your knowledge to a higher level. Sarah?
We're having a discussion back here that we probably need to start looking at our resident IPs more closely ourselves as mentors. At what point would you say for a PGY 1, 2, or 3 that those scores should flag us, right?
Yeah. You mean that what percentile level, or yeah? So for internal medicine, I can only speak for internal medicine because I only know the internal medicine data. I would say 35% or below is a score. So if your percentile score is 35% or below. The other thing that I do with my advisees is I look at how their score is improving each year, and it should go up. It goes up a little more between 1 and 2 than it does between 2 and 3, but the raw score should go up 5 to 7 points a year. If they're not going up 5 to 7 points, then they're not effectively learning in my book. So those are the 2 things. The raw score. Yeah, because the percentile
is where you stand at most.
Well, for those people, the percentile will keep going down. So if you want to look at the percentile, you can. But nationwide, it's nice to give them a frame of reference that's real. So you say most residents' scores go up 5 to 7%. Yours only went up 1%. So yours is low, and that in terms of behavioral motivation, referring to their peer group is actually very motivating. Drew, did you have a question?
I was wondering, how often do you encounter a resident that just rejects that ITE scores are a good measure of their knowledge? Because anecdotally, I can think of at least one example where they excelled in their evaluations otherwise, and they just had low ITE scores.
I could give you 100 examples of what you just said. There are a lot of people that do that, and so there are some people that reject that, and there's some truth to that, right? I mean, there's some truth. I mean, I'm not I'm not standing here saying that ITE scores or board pass rate scores are the primary, but it is one of the core competencies. And when I have the advisors do the questions and that they get some of these questions wrong, the advisors go, oh, you know, I mean, it is a little startling to see that somebody could miss some of these questions. I do have people that reject it. I've had two people that when they were asked to meet with me said, I don't have a problem. I don't want to meet with me. You know, I don't have data other than to say that both of those people failed. But that's not real data, right? Like, that's my anecdotal case of two, right? Right? So.
But can I just respond to that a little bit too, because I think it's not the be all end all.
No.
But I think being that low is a problem, and
Right.
I think it is disingenuous not to say that it's a problem.
Right.
Yeah, no,
Right.
I completely agree.
Right.
I think that it's an important one measure of
Right.
medical knowledge and something that we're going to have to
Right. Right.
credentialing going forward. So do you try to reframe their thinking for that learner, and have you found any ways that are more effective than others?
That one was particularly the counselor.
Yeah, I mean, this is something I do. This is not an I mean, I don't have a research project going on here or anything like that. I just do it to help people, right? And you know, and so if they don't want my help, I don't care. You know, I mean, I really do care, but like, it's going to require. I mean, this is going to require a couple hours of my time and a lot of hours on their time. And if they're not interested and not motivated, yeah, I can't. Yeah, if they don't want to meet with me, they don't want to meet with me. You know? Yeah. Huddy.
Has there been any consideration of like explaining what the ITE is to residents before they become deficient? Because I remember anecdotally, I didn't know what the heck ITE meant or what my scores implied until you explained in the medical education meeting last year.
Right.
And now, literally, just as you were saying, I'm supposed to be increasing to 5-6%. I'm like looking at my ITE scores and seeing if they've been increasing.
Yeah. Right.
No one had ever said that. And
Right.
So, like, I feel like if learners knew that from day one, then they would, if not take it more seriously. Sometimes it's hard when you're taking on your only day off of the week and you're coming off nice. But at least, like, then be more motivated to learn. Because I think a lot of learners are self-motivated, but they don't necessarily know the implications of what this
Well,
is.
you're also talking about goal setting, right? How many people know
Yeah.
whether they're learning?
Right. Well, then I don't think there is any goal setting. I don't think.
So when I came.
to know what it is. You just
No,
like, show up next
no one
Thursday,
explains
it's
what it
6
is.
hours.
Yeah.
At any point while you're taking it, at any point after your scores, they tell you, oh, your scores are available, go look at them. No one says, this is what it means, this is what you should be aiming for. If you get this score, it means you have an X% chance of passing. If you get this score, it means you have an X% chance of failing.
So when I came here, my job was to be the program director for the Shady Side track, and we had more issues with board passage. So we did. I would say, you know, the IT's coming up, or the first time they got their score back, I would do it at a noon conference. So I have done that. I think you guys are a little bit of a victim of your success, right? Like, most people do really well. So, but that's a high level decision, you know. I mean, I think I think, to be honest with you, I think it works best that the advisors know it and the advisors sit down and go over with you, you know, because then you're looking at them with a trusted coach that's going to go over that and say what it is. And I have given this talk to the advisors, a different version, more focused on internal medicine.
Can I just follow up on that just briefly? So what's the rumor mill about it? What do
I
people
know
talk
there is
about?
one. I remember distinctly in my second year. They sent out the scores, and then Dr. Gladwin sent out this email being like, "Oh, we were 99 percentile," and all these people texting me, being like, "Oh my God, does that mean if I didn't get 99 percentile, that I'm like doing really poorly?" So like, honestly, none of us know.
Yeah.
There's like not even a rumor mill because we don't even understand.
So I left this piece out, but it was designed to be a formative test to provide feedback. And so in my book, and that's the best way it acts. So comparing yourself against classmates isn't really the goal, but your advisor should be going over this and saying, here's where you're going. Tell me a little bit about this. What are you studying? You know, here, you know, and for the people that are really low, your advisor should be helping you set up a program.
That places a lot of trust in the advisor system.
It does.
'Cause there's
Yes.
a lot of agendas. Yeah, I'll pass it on to Jen. To talk
Like
about.
my advisor left for Butler VA and I haven't seen her and talked to her about anything, honestly, but since you only did 2 years, so.
Okay. Well, you can always talk to me.
I learned in these sessions.
Right.
Also, all the ACP information about what this session is for, it's like readily available on the ACP, like on the website where the IT comes.
Right.
Like any resident can find it and read about it.
Right. And I just showed you the score sheet. The ACGME, they give them the ACP gives them a booklet. It tells them what questions they got wrong, what were the learning objectives for each question you got wrong. So you could literally go there and say, in cardiology, I don't know anything about pancreatitis. I don't know anything about when to get an echocardiogram in an asymptomatic murmur,
So I
you know.
want to switch the conversation in the last 2 minutes. I also need to make an announcement for Gen Med people, journal clubs in Berkman today, so just so y'all know that. The thing about the medical students I think we need to think about is there is, I feel, for many of our students, this is great belief that as long as you're passing, you're fine. And that sort of aspiring to have higher scores is not necessary and is a detriment to wellness. I've actually heard students say, if you're above the mean, you're working too hard, you know? And so one of the challenges, I think, maybe this was, since we're 2 minutes tonight, is for another session, is to think a little bit about, I mean, there's sort of two pools, right? One is the learners who need to remediate, and the other is taking students from okay to great, you know, and how we trigger that motivation and make it important without making them crazy, you know, and I think that's sort of the holy grail, at least in medical student education right now. You know, we talk about sort of the USMLE and should it be pass-fail and what do we do with it, but it is incredible to me how many students are comfortable being sort of the bottom of the pack across the board in every thing. I mean, everybody can like have one area that they bomb. You know, you can bomb genetics, or you can bomb cell signaling, or you know, whatever. You know, I mean, there could be an area, but if you're at the bottom in everything, that to me is, I think we need to increase the angst about that. So, just do that.
All right. I'm going to finish up there. Thanks for your participation. I appreciate the questions.